Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Nick Biasotto. I'm the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. Today I have a special guest and friend, Michael Axe. He's a physician, a retired orthopedic surgeon. A little bit about him. His undergraduate work was at Bucknell University. He then received his medical degree from Jefferson Medical School, Thomas Jefferson Medical School, and he did his residency at the University of Pittsburgh in orthopedics. And he did a sports medicine orthopedics fellowship at James R. Andrews Houston Clinic. He's professor at the University of Delaware Physical Therapy and Mechanical Engineering Cartilage Lab. That sounds interesting. He's also had University of Delaware Honors College Advisory Board and chair of the Health Professions Network. He's been the chair of the Medical Society of Delaware's School Health Committee. He's also past chair and founding member of Sports Medicine Advisory Committee, Delaware Interscholastic Athletic Association. Welcome, Mike. And now, Mike called in saying that he wanted to talk about corticosteroid injections into joints and to debunk some of the previous myths about these injections. Welcome, Mike.
Thank you. Thank you for having me.
Well, tell me what you mean by you're going to debunk the...
Well, we have heard for years that you can only have a certain number of injections into the joint.
Correct.
And the fear was that it's going to propagate osteoarthritis.
Mm-hmm.
And the thought was that it kills cells and made them non-functional, the chondrocytes, which are the active cells of cartilage.
Mm-hmm.
There was also a thought that you didn't produce any cartilage cells after you had your original group, and we've found that everyone agrees that that's not the case, that
Okay.
you do continue to make cartilage cells.
I do remember when I trained, I was told no more than 4 injections a year in a joint. I don't know if that still applies. I guess not now.
Oh, no, it still does apply, and
Okay.
that's why this work is so important, that it's still even talked about as recent as 3 weeks ago.
Okay.
But they don't know why. They don't know why. They just thought that it killed cartilage. They were told by someone that cartilage cells die when they're put into an area in which they have to be, the corticosteroid is around them.
Okay.
Okay?
Uh-huh. So what is the present recommendations that you feel should be applied in this situation?
You have no restrictions.
None.
None. No, you should give them. And I wanted to kind of bring the listening audience up to a concept of wet joint versus dry joint.
Go ahead.
So wet joint is one in which it has fluid in it. And the University of Delaware has determined how to actually grade that. And it's accepted around the world as a grading for swelling.
Mm-hmm. Is that an effusion, like a
It's
joint effusion?
Yes.
Okay.
Well, some people will understand that. Yes, joint effusion. And
Swelling of the joint.
These
Okay.
are grades of that swelling.
Mm-hmm.
And certainly if you have a grade, they go trace 1, 2, and 3. There's earmarks for how to decide which one it is. If it's more than the 2, you should take the fluid off.
Mm-hmm.
And that's usually when you should inject the corticosteroid.
Mm-hmm.
Now, that effusion indicates the amount of irritation of the joint or synovitis. The corticosteroid is there to treat the synovitis.
Mm-hmm.
It's not there to treat the cartilage.
Mm-hmm.
So the hopes are that by treating the synovitis, you don't kill the cartilage in the process, so you don't throw the baby out with the bathwater, right?
Right.
So that's what we went into that whole idea. And not all corticosteroids are created equal.
Okay.
So all I'm saying about for safety is that triamcinolone acetonide is safe.
That's the one
I
use.
can't,
Mm-hmm.
and you and most of the other physicians in the United States and Europe,
Mm-hmm.
with the exception of the UK people, they're forced to use dexamethasone
Okay.
by their healthcare system. But we in the world, like TA, and hey, it's I can give you all the chapter and verse on why others have had their thoughts about things and why I've changed my mind.
I usually mixed my triamcinolone with Bupivacaine, so it's a little bit of a numbing agent. I don't know if that does anything or make me feel better.
My other study shows that Bupivacaine does kill cartilage cells.
So
that may not be as good an idea.
Okay, that's how I originally tried.
No, I know. And another thing that I studied was what's Bupivacaine do in and of itself, and what does Lidocaine do? So those two things are now part of that. So, yes, I can discuss what we've found, but probably the most important thing is the lab and what resources we have and why it's different. Why is today's research different than those of the past? And even people who have discussed the research last summer, where still their methodology was questionable. They interpreted their facts right for the way they did it, but it wasn't physiologic.
Got it. Interesting. I usually like to see results right away. I know cortisone corticosteroid takes a little time for it to kick in. So that's when
2 days.
If I do AC joint injection, I like to say, okay, can you move it now because I got the Bupivacaine in there? And they say, oh, yeah, I mean, really good. I said, well, that'll wear off and the cortisone will kick in later. So,
no, your point is well taken. Now let's go ahead. That has a very little articular surface in that joint.
That's true.
You're not hurting anything.
Okay.
Subacromial space, if the rotator cuff is intact, you're not hurting the interarticularly.
Okay.
So that's okay.
Okay.
If you're doing tennis elbow, you're not going in the joint. That's okay.
Okay, got it.
So most of the time, the articular cartilage is not exposed, but if you're putting it in there, you probably remember years ago when the manufacturers came out and said, we don't want to have postoperative shoulder pain after having a capsular stabilization.
Okay.
So they put a lidocaine pump in there so that it was constantly bathed for 2 days.
No pain,
Cartilage
no
all
pain
died.
at all.
Cartilage all died.
And the cartilage died?
Cartilage died.
Huh,
okay?
Interesting.
So that's when we started looking at lidocaine toxicity. And what the impact is on cartilage cells. And it has a significant, for triamcinolone acetonide, and I'm just going to say TA because it's easier to say, that has very little effect on viability. Less than 2% of the cells die. They also continue to proliferate like they would if they didn't have the triamcinolone acetonide.
Interesting.
And then go one step further. Their metabolic activity is minimally affected as well. And you're saying, well, that isn't what they found when they did single sheets of cells. The way they studied it before is they took a single sheet of cells, say that 3 times fast, and they bathed it on all sides. But what you really need to have is a cartilage plug. So that's called an explant.
Okay.
And by having a full thickness cartilage plug, you have a top and you have a bottom and you have the sides.
Right.
Where this had it all top and bottom, but it was covered.
Okay.
Now, we did the same immersion. We still soaked it in that. And not only did we soak it in a concentration that was 80 milliequivalents, twice what you would use per ml. We did that. We left it in there, that cartilage plug, for 14 days. So that would be like giving a shot every day for 14 days.
A shot of
TA. And nothing.
Nothing happened.
Less than the 10%. So we didn't believe it, so we repeated the study. And nothing happened. So then we looked at it, well, it was just on cows when we first started. Well, maybe it was a cow thing, right? So then we took the remnants of after a knee replacement and used them. So we took them right from the OR over, did our plugs, and studied them. Then we were nice enough, a company called Allosource from Colorado, the donor bank, then made human cartilage available to us. And we would have it from the time the donor expired until we did our plugs, 4 days. So we've taken all the variables out. So we did plugs instead of sheets. We did it fast. We did the concentrations that we wanted to do that were realistic. Why 80? Well, maybe use 2.2 cc's. Right. You know what I mean?
Right.
So we not intentionally.
Okay.
But suppose you screwed up. And you say, oh, man, I wish I wouldn't have done that. What has happened? It was fine.
All right, really?
Really.
Are you published in this area on this
Well,
subject?
the answer is yes, that the manuscript is in place. Now, I elected to hold Dr. Lucas Liu is the person in charge of the cartilage lab. And his chief person is Annie Porter. She's getting her PhD. And we have several others that are involved in the lab as well. But Annie's did the most of this research. they have all the equipment, and this was all available. And I said, I want to come in and I want to study steroids. He says, well, why do you want to study steroids? We want to do something else. I said, because everybody wants to know the answer to this. And he said, well, in my realm of research, it's the work's been done. I said, well, the work's been done wrong. Okay. And he said, well, we have brand new, why do we get different results? Probably the most important thing. In 2022, this click chemistry from which we work won the Nobel Prize. So they didn't have it before.
Right.
So in all fairness to the people there, the scientists before us, they didn't have the ability to be able to decide to determine what the metabolic activity was of the cells. And now we can.
Interesting.
So we could tell if they died, and we didn't die either. So we think the dying part that they did was the single sheet of cells. But we know the metabolism is a whole different ballgame.
What do you mean?
Well, we're able to show that it didn't hurt the metabolism.
Got it.
That it didn't even go to sleep. It just slowed down.
Interesting.
Yeah.
Interesting. Well, you've turned my feelings around about adding the Bupivacaine, so I'll
Sure.
be limiting that usage. Interesting enough, we talked with your partner about platelets and plasma-rich platelets. That is quite interesting because when I was the director of the wound care center at Christiana Care, we used a compound that was made from patients' platelets. We would get their platelets and we would harvest their platelets from a small aliquot of blood that we'd get, and we would place that on the wound bed after making a poultice with it, and it did fantastic to the wound beds. It wasn't cost effective, so it wasn't, and insurance didn't pay, so it was. We had our own lab to do it and everything, but it was put aside. That's a shame. But here we are with the steroid question, and I just can't wait to see your article. So how long is that going to take to get published?
Well, you have to go through the process. So first so let me explain to you why it hasn't been published yet.
Okay.
Rather than do it piecemeal, I wanted all the information done. So let me tell you what we've done. The first thing we did is we got our methodology down on 2-month-old bovine. Then we did the OA because we wanted to know what the difference was between bovine and OA. Then we got access to the healthy human cartilage. So first thing we started to do is safety. Like any drug study, you start with the safety of it first. So we then said, okay, let's do these experiments, and we proved that it's safe.
Okay.
So we're moving forward with the safe. So we had to have access to the human cartilage that was healthy. We only got access to that 6 months ago.
Okay.
So we could have put out the bovine. Who cares? It's a bull, right? You know. And then you have the second one, which is that you have the osteoarthritis. Now we learned some really good things about that, but we got that readily available because the people First State Surgery Center said, sure, you can take that. Why can you do that? Because it's de-identified. All we need to know is age and gender, and they were throwing it away. So it was surgical remnants from the procedure. So we weren't taking a piece of anybody's stuff. They were going to put it in the can.
What's the secret about the osteoarthritis that you said?
The cells that are there amp up. So the ones that are still there increase their metabolic activity.
Really?
And they talk to each other. We have another part of our work is on cartilage talk. So the chondrocytes talk. And the chondrocytes that are from osteoarthritis talk a lot more than the ones that aren't from osteoarthritis.
Okay, boil that one down for me. What do you mean talk?
They actually communicate amongst themselves through calcium channels.
Okay.
And they actually increase their metabolism. And it's thought that this one talks to this one to say, hey, you got to produce more stuff.
Oh, wow. That's interesting.
It is. It is. So let's continue on.
Okay.
So we have the safety stuff. And we said, well, that's nice. What happens when you have inflammation? We gave it in the first place for inflammation. So we put in an inflammatory component to it to see what the impact of the inflammation was on the articular cartilage. And it hurts the articular cartilage.
And you have the anti-inflammatory effects of the corticosteroid.
Well, we put the corticosteroid in for the synovium.
Okay.
The cartilage got hurt because of the inflammation.
Okay.
So we're not putting it in for the cartilage. We're putting it in for the synovium because we want that calmed down.
Okay.
Hoping, like with cancer therapy, that there was going to be a rescue. But it didn't. But what it did do is it lessened the effect of the inflammation on the cartilage.
Okay, so it lessened the cartilage inflammation,
but not enough to speak about.
Okay.
It didn't really help that in this state. So if you had an inflammatory component already present, we didn't see that uplift that you would hope for with the steroid in the cartilage. But that's not what we put it in there for. We put it in there for the synovium to control the inflammation.
But on the secondary
But let's go with the
side,
other thing, though. Weren't we afraid that with that inflammation, by giving steroid, we were making it worse?
Why?
Because the cartilage itself, if this steroid is so bad, and you give the steroid to the cartilage cells and you're already hurting, the inflammation's hurting them and the steroid's hurting them. The reason why you did that was to control the inflammation.
Correct.
But think back through this now. The steroid cells, the steroid effect on the cartilage cells, we were told it made it worse. We're now telling you it doesn't. Okay? So you don't have to worry about it. If you have a swollen joint, you can still take it off and give them another steroid shot in as short a period as you want.
Got it.
And that's what we're trying to do without hurting the cartilage in doing it. That was what that whole thing is. And for heaven help you, even if you did it for a dry joint, they didn't have a swelling. Mm-hmm. You just did it. But I recommend PRP and viscosupplementation for dry joints. Okay. We can get to that whenever you want to. But you don't have to worry that you gave multiple aspiration and injections to control it.
All right, now let's get back to the amount I can put in the same joint in a year. Still 4?
No, as much as you want.
As much as you want. Okay, that's one clarification.
Only TA. I am only talking about triamcinolone.
That's all I use.
You're not alone. There's other people listening. They may use something else. Okay. And I don't want them to think that I'm saying all corticosteroids are good to the cartilage. I don't know they're bad.
But
I don't know they're good. It's okay.
Okay.
I know it's okay.
So the others, like dexamethasone, may be okay.
No, it's probably dexamethasone. The reason why TA is so good, there's a picture of me trying to fit into a turtle shell in the Galapagos Islands. It's a big turtle, and people can try to get into it. So I tried to get into this shell. This turtle weighed 400 pounds. So I figured I could fit in the shell. I got about 2/3 of the way in, and I didn't get stuck, but I was worried about getting stuck. So I came back out. Well, I used that picture to show what triamcinolone does. It has big crystals, and the cartilage has pores. And the crystals are so big, they can't fit into the pores. So in order for us to do an experiment, we have to artificially add DMSO with that to dissolve them.
That's dimethyl sulfoxide.
Right. Mm-hmm. And with that said, the crystals then were made, they were dissolved. Mm-hmm. And all our studies that shows it's safe is after it's been dissolved, not even with the pure crystals, which is insoluble. So we had to make an artificial state to show that it did anything.
Right. So you still didn't tell me how, I guess the crystals are smaller in dexamethasone? Or
no, they dissolve. The whole thing is more soluble.
Okay.
They don't have to use DMSO.
Got it.
They're able to do that. And there's solubility curves, but triamcinolone is one of the least dissolvable.
Okay.
Now, if you look at some of the products like Zilretta, they went one step further. When we use regular TA, we know that their blood sugars go up.
Yes, definitely. That's what I was going to ask you. Sure.
And with them going up, within 2 days, most of the triamcinolone is either in the synovium or has been forced out by the lymphatics. For that first couple days, the concentration is very high in the joint. Well, with Zilretta, which is a long sustained TA, that gets sucked up into the synovium like Pac-Man. It actually bites it and keeps it there and dissolves over time. So the second part of our study was with the amount that you would have in Zilretta and have it for extended periods of time because we wanted to see what the impact was of low dose. We knew high dose was there, but we also studied that concentration that we got from some of their work that they did for their submissions to the government.
And Zilretta is triamcinolone in a long-acting nature?
It is. It's in little particles that get absorbed into the synovium and they dissolve over time.
Oh, interesting.
And they're there for about at least 6 to 12 weeks.
But you brought up the fact that if you're diabetic, you're going to watch those sugars in a few days after the injection because they
100%.
do rise. They
100%.
do rise. And I tell my patients that are diabetic, and I tell them how to deal with it at that point.
And if you give them another shot in a short period of time, the diabetic, I don't know what the impact would be on your adrenals if you had repetitive shots because of the leakage. I don't know that you wouldn't make them, give them adrenal insufficiency because of the shutdown in their adrenals. I can only say to you, you don't have to worry about the cartilage. I did not say you don't have to worry about the medical problems.
Okay, all right, but I have to worry about the medical problems.
Yeah.
So, you don't want to give a high enough steroid to suppress.
Well, you want to make sure that their sugar's back down.
That's right.
So if their sugar is back down, then you could give them a couple of days, but that usually is within a week.
Uh-huh.
So you're still safe doing it every 2 weeks for sure.
Got it.
You're not going to affect the adrenals probably, and you're definitely not going to affect the cartilage.
And you're not going to affect the sugar and the adrenals. You won't have suppression of cortisol, so everything seems to be good in that regard. Yes. Interesting. So we've made the distinction between the cartilage and the synovium and how the steroids do work at that point. We made a distinction between the triamcinolone and the dexamethazones, and the fact that you always got to watch out for the secondary effects metabolically and medically if you do give steroid injections. That's pretty good. Okay, I'd like to take a short break now, and we'll be back shortly. Thank you.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
We're back from our break talking with Dr. Michael Axe, who is a presently retired orthopedic surgeon, but still doing a lot of research to either prove or disprove many of the myths about corticosteroid injections into a patient's joint or synovium as we talk. Now, people are concerned that sometimes corticosteroids may enhance the development of osteoarthritis.
Yes.
Is that true, false, or maybe?
I think it's false.
Mm-hmm.
The fact that arthritis is the loss of healthy cartilage cells,
Mm-hmm.
and what our research has done has shown that triamcinolone does not impact healthy cartilage. So that part is less of an issue.
Mm-hmm.
No one wants to have a knee replacement,
No.
or they want to delay it as long as possible. So all these things that we're talking about with your PRP
Mm-hmm.
and your viscosupplementations and corticosteroids, what are we trying to do? We're trying to delay having a total knee until we're in our 60s. Why? Because we know they only last 15 years, and we know the population is lasting longer.
Correct.
And we know that the complications after a primary to a secondary revision are way up.
Yeah.
The costs go from 1.5 to 2 times as much as the first one. You don't feel like recovering from it. So everything we're doing right now, steroid is the first line of defense because it's cheap.
Right.
Okay, the second line of defense for a dry joint is viscosupplementation.
Gels, they call it, right?
Mm-hmm.
Mm-hmm.
And if you have if you're able to afford PRP,
Because it's not paid for by insurance at this point.
if you have the resources, you owe it to yourself to try it, to see if indeed you're fortunate. Because I've seen doctors straight have knees that I swore to heavens were going to have to be replaced in people that were very heavily into martial arts who wanted to continue doing that.
Mm-hmm. Mm-hmm.
Okay? He injected them, and they're now 5 years from they get repeated. They find the resources to be able to do it yearly so that they can continue on with their martial arts. Now, I like it because I want to get them to those 60s because they're going to live to 80s.
Of course,
okay?
of course. I guess the secondary, if you have to replace it the second time, say they got it at
Yes.
55 and you're going to have to wait 15 years, and let's say it's now 70, your real problem is all the scar tissue and all that develops around the replacement, correct? Or is that a big problem, or is others the problem?
You'd have to talk to revision guys, and a lot of people do primaries and then they send them to another person for the second one. And they do that for a reason. They do that for a reason.
Understand.
And if they had to wait, now, in all fairness, if we had to wait for the guy that does the revisions to do all primaries, you'd be waiting for, we have one surgeon downstate that his wait time is 6 months.
Ooh.
To be able, and that's for any of them. And he still does 10 to 12 a week.
Oh.
But they're waiting 6 months because they want him to do that. So many of our young doctors, we had the the first thing that people wanted to do in orthopedics was that they wanted to be joint doctors, because that was a new thing that came about. It really improved the quality of people's lives. The second group of people in the 1970s heard about sports medicine. And at the time I did a sports fellowship, there were only 2 recognized programs. Okay? And then they had some others that weren't quite as recognized. Well, now it's the number 1 sought after fellowship. Well, those jobs are pretty full throughout the country. So what's come back? The total joints. Okay? Because so many people are living so long. And we're doing it on people that are 75. There used to be a time that we wouldn't do it on a 75-year-old.
That's happening more often.
That's gone. And somebody that does it on an 85-year-old, they are not doing it for the money, because those joint surgeons don't make that much money. Just so you know.
Okay.
And they don't make any more for the hard ones or the easy ones. It's the same pricing. And what used to be 25 years ago, they're making about 20% of what they did then.
Right.
So I want the listening audience to realize that they're not doing this in an 85-year-old because they got nothing to do. They're doing it because the 85-year-old doesn't want to be 85 years old physiologically. They want to be able to do, they know they're a burden to their family, and therefore they want to get up and get after and do things. So all the things that we're talking about today, if I made any contribution to the fact that doctors can feel comfortable giving steroid shots and not TA, and not worry about making the arthritis progress, then I did my job.
Great.
Yeah, I did my job.
So I guess we've got alternatives to surgery, because you really want to do that to prolong that event.
Just get to 65.
Okay.
Yeah.
Get to 65, then it's considered okay. You get to 80 before we'd have to do a new one, and it probably ain't going to happen, but maybe it will.
Yeah.
So we've got the corticosteroid injections, TA.
Yes.
We've got the gels, which
Yes.
are out there and do a marvelous. I don't do that, but I know that ortho does it quite a bit, and the patients say they really like it.
Yeah, I've given 30,000 of them.
Oh my God.
Okay, just to give you kind of an idea.
Wow. And the last thing on the thing would be platelets before surgery. So you got 3 options before you go to the next.
Well, don't forget the one we didn't talk about.
What's
That's
that?
physical therapy.
Of course.
No.
I always
We have
say
found, I'll wear my professor of physical therapy hat now.
Okay.
Having taught in that curriculum since 1990, and my wife, Lynn Snyder-Mackler, is a professor of physical therapy in their number 1 PT program in the country.
Oh, wow.
There. That's the University of Delaware, is that good. We have found with our arthritis studies that is very important for the success of these other things.
Okay.
Because if you're weak, or you have in either your knee or your hip, and you're walking funny, there are some braces you can do and some strengthening you can do. These things are all part of it too. You can't expect a person who has arthritis, you have to correct something. And if you can do it dynamically with exercise or with bracing to help change the weight from one particular area to another, that's very helpful. And I have spent a lot of time in my publications prior to the current ones have all been in the physical therapy realm, with a couple of other things, baseball and some things that I've done. So I feel very comfortable with the topic of why physical therapy is so important and the time you have to spend keeping strong.
Like I tell my patients, therapy is important. They got low back disease. Tighten your core. Learn some exercise to keep the core tight, because that gives you a little more strength and a kick.
So I'm going to ask you a hard question now.
Here we go.
Are ready?
Yes.
So how many physical therapy visits do you think it takes for the patients to really learn their exercises?
I usually send them for 6 weeks and hope that's it. If they don't
good.
learn it by then, they don't learn it.
That's good. Yeah. Some people do a home exercise program.
Yeah,
It doesn't work, and I want to caution the people out there that at least when you go twice a week, you did your exercises twice a week. So I would always tell my patients you need to go 3 times a week, because after the first 4 weeks they go twice. They find a reason.
Exactly.
They find a reason not to go,
and they want to do it at home.
And I get that, and they do pay up. I mean, they're paying their copays, so it isn't like the therapists have a charge. And it can be costly, and they're going all the time. Where they see us for our copay once every month, they're seeing them
every week.
Right. Or no, twice a week, sometimes 3.
Yeah, 3 times weekly, times 6 weeks. Yeah, okay. That's a little bit high of a copay. I could see in a knee joint, you would want to tighten the quads, you'd want to tighten the hamstrings. You want to do all that so the knee is more stable and stronger.
And your hip.
And your hips.
And your ankle. But I'll tell you when I had my knee replaced, the thing that I didn't get back is because I'm a thick-thighed kind of guy, I got heck in Europe trying to ride on the back of a small vehicle, because you have to bend your knee 125 degrees, and I only had 122.
Ooh.
So I want to tell you a trick out there. If you're going to go off and you've had your knee replaced, get on the rowing machine and get yourself moving back and forth into the biggest bend you can get with using your arms, and it'll make your time a lot better.
Oh, interesting.
The rowing machine is the key to getting those last 3 degrees, particularly. You don't always do it. The only time I'm in that much bend is in the back seat of a small car.
Interesting.
The rest of the time, I'm not there.
Interesting. So your goal is 125 degrees?
125 degrees, you can get almost everything done.
Okay. Well, an interesting topic that I understand that your daughter, Michelle, acts as a big proponent of is food is medicine. How does that apply to your orthopedic patients?
Well, we have a fair number of people that are diabetic. 35 million diabetics in the United States, of which 45% of them have degenerative arthritis of the knee. We talked about earlier the impact of steroids on their medical problems, but the dietary importance is even more so. And let's go one step further. We didn't talk about metformin and the positive impact it could have on osteoarthritis because of the way it helps the environment and control inflammation.
Okay, cool.
So she is involved with her program is with Christiana Care, and they're studying the readmission rate for diabetic mothers and how did they control their postpartum sugar levels. So they provide both the food and the information to have these, and they're looking at, she gets her report card by the readmission rate.
Oh, wow.
So they took this, she also interacts with all the farmers and making sure that they provide the produce and distribution on who gets it and how it's gotten.
Wow.
And then so nothing goes to waste. So she's now working with Lieutenant Governor Gay to be with this food as medicine concept, for which...
Well, in the future, I think we're going to ask Michelle to come in and talk a little bit about food as medicine.
She will be a very entertaining guest.
Great.
And she started, just so you know, she started out as a hotel and restaurant management person at the university.
It's a big jump.
And not really, and she was an outstanding cook. So therefore, she won the soup award, which is given to the student at Delaware who makes the best soup in their discipline. So she won that one. And then she also worked at Vita Nova, which is their student-run restaurant.
Okay.
And was the back of the house. I think the chef part of it. The front house and back of the house. And then she combined this with medical statistics. She has her master's in communications, medical communications.
Oh, wow, interesting. She's on our list. If she's willing to do it, we're willing to have her on one of our shows in the near future. Anything else that you'd like to add?
I'd like to add, for those people out there that are interested in doing clinical research and working within a lab, I took a problem to University of Delaware, and other universities have great resources.
Yeah,
you got to find them. Okay, you got to have a development person go in and put these two parties together.
I did my master's at the University of Delaware in biochemistry, and I did a lot of research. I got assistantship. Everything was paid for me, which was wonderful. Books and courses and the like. And I did the research for the professors that they wanted to proceed, and many of them put me in on their publications. It was quite an honor. I thought it was very good. It was interesting as hell. That was before I went to med school.
Yeah, and that's not uncommon. We have a fair number of people that I sit on the Honors College, the advisory committee for the Health Professions Network. And that's my job, is to get the students to be able to rotate and do their shadowing and their other things and what they want to do in their gap year, okay, and so forth. That's my role. And what we're recruiting is all the now physicians who graduated undergraduate at Delaware, putting them in a network that we have an ability for them to call those people
interesting.
and interface with them.
That's good of you, Mike.
But the university setting, particularly Dr. Lucas Liu, I have such faith in our results because I have faith in him.
Good.
And his network and his equipment.
And his name is what?
Lucas Liu,
okay.
Dr. Liu. And Annie Porter is getting her PhD, and she's done all this research.
Okay.
So she's the expert. And it is coming. You asked earlier, when is it going to be available? It's going to be available, I would say, for public consumption in September.
Okay.
We are signed up. I'm doing the AOSSM and the AOS, which are two big orthopedics. I presented it at the World Soccer Federation meeting in Madrid 2 weeks ago, and it will be coming out there, and the physicians are going to want it in their hands. We expect to have a little bit of pushback from the people who did the methodology a different way, but the physicians are so excited because they want to hold it and say, I didn't screw up.
Interesting. Will you sign your copy to me, please?
Yeah, I absolutely will.
I would appreciate it.
Absolutely will. I'm very happy with making that kind of difference.
Okay.
And people, we have, this is probably, I designed a baseball card that you can actually have a young person throw anywhere in the world, and I can tell you, project what's going to happen for them. That we did I went to Japan and Puerto Rico and all these other places, and we actually studied these people. And I did that back in the 90s.
Tell me what that means.
I can actually, you can't see it obviously, but I have a baseball card that you have a kid that throws based upon his age, if he's under 14, and how fast he throws. I can tell you how far he throws, and I can also project where he'll be in the future.
Interesting.
But that didn't catch on because there weren't enough people that played baseball. So that was the most important thing I did till this. The stuff I did at the university with regards to ACL recovery was important. Don't get me wrong. It applied to my patients. But that was mine, and this is mine.
I understand. Well, it's been a pleasure, Mike. I've really enjoyed this conversation. I've learned a lot myself. I thought I was doing everything right. I guess I was.
You are.
And I want to continue to do
now
things
modification.
Right. Just modification. Okay. We just finished our very interesting podcast with Michael Axe, in which he debunked a lot of things that orthopedics as well as primary care physicians have done or worried about, that is, in regard to corticosteroid usage and injections in the joints. I hope we have you back again when you're published, and maybe go over it one more time and pull out some very interesting things.
Well, we're doing other things. We did inflammation. Now we're doing other scenarios.
Okay.
So we're actually doing a push-through study where there are 2,100 drugs, and we're going to actually study them to see what the impact is on the metabolism, to see, like Rogaine,
yes,
where they found out later it was great for hair, but
right.
It was really a hypertensive medicine.
Right.
Well, we're looking for other medicines that are healthy for cartilage.
Interesting. That's something I'd like to know, really. So I'm getting old too, you know.
Metformin is, you're going to find that the diabetic drugs of today are going to be helpful for your arthritis. Not only are you going to lose weight, it's going to help your joints.
Interesting. You mean the GLP-1s?
Yep. They're anti-inflammatory.
They're saying everything about those drugs now. They're going to slow down Alzheimer's, reverse sleep apnea. I mean, I'd like to see more studies coming out.
I'm only going to say to you that metformin is the base from which it works.
Okay.
And it looks like metformin. We're studying metformin right now to see what it is. The same study design.
Okay.
We'll be using other drugs.
Okay.
And we'll be using the levels in which circulate in your bloodstream as per the amounts that all the government tells you that you have to have safety studies. So you have to know how much you gave them and how much is in your bloodstream. Well, what we don't know, and one of my hopefuls is we don't know anything about the blood synovial barrier. Like we have the blood-brain barrier. We don't know what it is in the joint. So now we have some folks up in Boston, Morgan Jones, is actually taking the blood and taking the fluid out of the joint.
And seeing if it's in there.
And seeing how much is there. Or how much they compare.
So you're looking at it. There is a barrier between synovial?
Well, it doesn't seem to have the same amount. Yeah, there's a barrier.
Okay, cool.
Or maybe not.
Michael, it's been nice talking to you again. It's always good seeing you. And I'm definitely going to call your daughter in for a food is medicine discussion, that's for sure. All right, this is Nick Biasotto signing off for now on the Medical Society of Delaware's podcast, Delaware Healthcare Reality. We've talked with Michael Axe. Dr. Michael Axe is a renowned orthopedic surgeon in our area who's doing a lot of good research and debunking some of the old thoughts. Mike, if there's people that are interested in this, how would we get a hold of you, or how would we get this information out to the people that might want to dial in or call in or whatever?
I think I'd hold. Let's just hold until we have everything published.
Okay.
So I can give them direct references. We've been so excited and so fast doing these things. I'm not really ready for that.
Got it.
But by September, we should be close.
We'll be seeing you in September.
You got it.
See you in September. Isn't that a song?
It was.
Okay. All right, everybody. Have a good day. This is Dr. Biasotto, and I'm signing off for this time.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.